Hi, welcome everybody. My name is Catherine Wilson. I'm with Salud America here at the UT Health San Antonio. Welcome to our next webinar series. It is with Genentech. It is Let's Address Health Equity Together. In today's webinar, we are going to learn about how to fight El Silencioso. Sorry, I'm filling in today. So our moderator is Dr. Amelie Ramirez. Dr. Amelie Ramirez is the director of Salud America, and it's home base at the Institute for Health Promotion Research at UT Health San Antonio. She has spent over 30 years directing research on human and organizational communication to reduce chronic disease and cancer health disparities affecting Latinos. She also is Associate Director of Cancer Outreach and Engagement at the NCI Designated Mays Cancer Center at UT Health San Antonio. Dr. Ramirez?
Great. Thank you so much, Catherine. And thank you to our panelists and all our individuals who are listening today. We're really grateful for this. We're going to record the session so we can make it available to anybody who wasn't able to join us today. So again, we have a phenomenal group of individuals who will be on our panels. And, you know, El Asesino Silencioso, or high blood pressure, is known as the silent killer because it can spur heart disease and stroke and other cardiovascular issues. And so this is why it's often called El Asesino Silencioso. And we'll get our panelists to explain that a little bit more. But the rate of cardiovascular risk factors is very high among our Hispanics living in the US, and it varies by our different Latino populations. And while they may be aware of their health conditions, less than half of our Latino adults with a history of high blood pressure, strokes, or heart attacks have been able to control their blood pressure in a healthy way, as well as their cholesterol. And also, you know, diabetes has been impacting cardiovascular disease as well. So today, with our phenomenal panels that we have, will help us find solutions of how you and your family members can better control your blood pressure. Today, we have with us Dr. Carlos Jaén, who's a physician and professor and chair of family and community medicine at UT Health San Antonio. We have Dr. Lucy Torres Days. She's an associate professor of internal medicine at Columbia University, Irving Medical Center, and a recent leadership fellow of the National Hispanic Medical Association. We have Eric Livingston, who is a Latina heart attack survivor who will share her story with us and why she's prioritizing her health. And our first speaker represents our webinar sponsor, Genentech, a biotechnology company and a member of the Roche Group. So we are pleased to have here with us Dr. Pierre Theodore. Dr. Theodore is the head of patient inclusion and health equity, and also at the chief diversity at Genentech. He leads a team of people committed to ensuring accessibility and availability of pharmacological therapies for all at Genentech, an organization that has been dedicated to realizing the power of biotechnology and tackling some of the world's most complex health problems. So Dr. Theodore, tell us a little bit about yourself, and then also tell us how Genentech is approaching heart health.
Hey, Amelie, thank you so much for inviting us to participate today. And this is really a very important opportunity for us at Genentech. I just want to give a little bit of context, both to what we do in the pharmaceutical industry and my own personal journey in healthcare. So I trained many years ago as a cardiothoracic surgeon. I trained at the Johns Hopkins Hospital in Baltimore. And one of the things I recognized was that the impact of cardiovascular disease was varied across populations. We certainly saw certain populations that were more severely impacted by both uncontrolled hypertension and the downstream effects of that, including cardiovascular disease. And trying to address some of those population health differences by socioeconomic status and race and ethnicity was one of the very important drivers that led me to Genentech. Genentech and Roche is, at this point, more than 125 years old, as a pharmaceutical company focused on a broad ranges of disease, from cancer to neuromuscular disease and rare disease. But the number one killer worldwide remains cardiovascular disease, and associated with that are metabolic diseases as well. And we remain committed to addressing the most pressing diseases that confront humankind. So I want to just end up by just really relating a very brief story just that happened the other evening with some very dear friends of mine. And over dinner, we were talking about high blood pressure, and I asked just around the table how many people could tell me what their systolic and their diastolic blood pressure, and very few could. And I think this concept of the silent killer, El Asesino Silencioso, is so important because so often we don't recognize a significant risk. So we're delighted to support and engage in a conversation around hypertension today.
Great. Thank you so much, Dr. Theodore. And we decided we would go by first name. So Pierre, thank you for those comments. And next, I'd like to ask Carlos, can you describe the state of high blood pressure or uncontrolled hypertension among Hispanics, Latinos, and the challenges that our community faces when it comes to heart health? And why do people call it the silent killer?
So thank you, Emily. It's a pleasure to be here, and I'm excited to participate in this very important aspect of our community, and really an important killer of our community. You know, I relayed earlier that my own father died at 61 from untreated hypertension from a heart attack. It was devastating, and I think that's a reality for many of our patients and in our communities. Hypertension or high blood pressure, you know, sometimes it's important to make that distinction, because sometimes when we talk about hypertension, people think that it's just when you're tense. So if you're not tense and you're not stressed, you don't have hypertension. That's not true. Hypertension is much more than just stress. It's really a condition inside your body that needs to get attention and treatment appropriately. The reality is that the rate of high blood pressure in Latinos is similar to other groups. However, there is a greater lack of awareness, treatment, and control. The other issue is that for many Latinos, we have poor access to healthcare. We may not have sufficient coverage in terms of insurance. But even among Latinos, there is a differential expression. So there was a recent study that was done on the study on Latinos, where we looked at the different areas, or whether you're Cuban or Dominican or Puerto Rican or Mexican. And the reality is, for people from the islands, the rate of hypertension and lack of control was higher. So, you know, there's one thing is, the issue is it has to be identified, it has to be diagnosed, but also has to be properly followed. So when somebody tells you you have high blood pressure, oh, okay, I'm going to exercise more, I'm going to change my diet. But if you don't have the proper follow-up, it's difficult to make that transition. And frankly, that's why it's silent, because it may not give you any symptoms. And until you get a stroke, until you get a heart attack, or until your kidneys are affected or other organs are affected. So it is real, and it's affecting our Latino community in a very insidious way, meaning that you don't notice when it's happening. And the other thing that study showed is that in a 6-year period, 1 in 5 people who did not have hypertension will develop it. So it's important to also check your blood pressure as you go forward, because it could be that you're developing and you still don't know it. So when you went for an exam 5 years ago, you didn't have it, and now you may have it.
Great. Thank you for those remarks, Carlos. I appreciate it. And Lucy, can you please share with us the importance of taking a culturally relevant approaches to addressing hypertension or high blood pressure in our clinics, in our hospitals, and why that tailoring is important?
It's so important because, as Carlos mentions, the Hispanic community is made of different ethnic groups. And even within that group, right, it's some people may be more indigenous, and then they have a certain language dialect that is different from Spanish. And we have to know that the dialect of Spanish is important, and there's differences within each subgroup. And then the cultural aspects has a great implication. So we can't assume one fits all, right? And so we have to talk about diet and how that may change. What do they use as their seasoning, sazon? Because they may not know that I'm not going to put a name brand out there, but the seasoning they use has really, really high sodium, and that could impact their health. And then who cooks in the family, right? And maybe the matriarch that cooks. And then so with leading them in terms of how to guide them, how to improve in terms of what they are putting into their diets. Physical activity may be limited due to work constraints or what they believe in terms of activity. And one thing I recommend to my patients, they are also impacted by a lot of social determinants of health, that they exercise. Exercising can be dancing, and just doing it several times throughout the day as quick as possible by themselves or with the family to improve that cardiovascular health. And the cultural aspect too may include like herbal supplements, right? Or going to the botanica, and what do they use in terms of trying to create a holistic approach in terms of caring for themselves. And the other part that our community is very strong is respeto, right? Respect for the professional, the physician. They may not ask questions. They may not tell you if they're confused, and they may just follow through, but they may not also tell them that something is going on, that they can't get their medications, or they don't know how to take their medications. So it's important for hospitals and clinics to provide language concordant as much as possible care, because that has implications, and cultural humility in terms of their approach to defining care to improve health outcomes for the Latino community.
Thank you for those remarks and the importance of tailoring and providing culturally relevant information. Now I'd like to turn to Erica. I have watched your video, and I'm just amazed that you were only 41 when you had a heart attack. Can you please share your experience in your heart health journey?
Yeah, so I am complete opposite of what everyone has spoken about so far, as far as exercising, eating healthier. I ate healthy. I eat healthy. I worked out at the time 3 to 4 times a day. I took my medications. I took my vitamins. Just for reference, I'm 5'4", about 120 pounds. And I woke up one day 3 years ago at the age of 41 with a heart attack. And of course, I didn't know what it was. My husband had just gotten over pneumonia. I thought, oh my goodness, maybe I have it now. But I woke up at 5:30 out of a dead sleep with sharp chest pain. Quickly, it radiated to my back. So then my back was hurting worse than my chest. So I just got up and I walked around the house. I'm like, let me walk this out. Let me just figure out what's going on, because I'm too busy to be sick. I don't have time. So then all of a sudden, I was freezing, I had chills, and then I started sweating profusely. Like it was like droplets just coming out. The floor was wet. Then I started kind of freaking out a little bit, thinking, okay, this is just not right. I don't feel right. This is not good. I ran a warm bath thinking I just need to warm up my body. I have an autoimmune disease where I get cold and my fingers turn purple and blue. And I just couldn't get comfortable. And I finally yelled for my husband. And he runs in the bathroom and he's like, "Ooh, you don't look good." I'm like, I don't feel good. I do not feel good. And I'm very stubborn and I have a high tolerance for pain. But he asked me, he goes, "Do you need to go to the hospital?" And I said, "Yes." Because something inside me is just not right. We are so busy as human beings, mothers, wives. We wear so many hats that the last thing we want to do is take care of ourselves and listen to our body. I did, thank God. And so we rushed to the hospital, immediately did EKG, and they come in there and they're like, "Ma'am, you're having a heart attack." And I just went into shock. There's no way. No way. I check off all the boxes. There's just no way I'm having a heart attack. Then my mind's going like, do I have heart disease? And high blood pressure does run in my family, and I do have it, but I never thought that's heart disease. No one thinks that. It is. It is a heart disease symptom. So I went from one hospital, they transferred me to another, and they had to go in there. My main artery was shut by 75%, and they went in and put a stent in. I had to learn to work out all over again, but now I'm working out every day. Even if it's walking, you don't have to have a strenuous workout. You don't have to kill yourself. Just walk 30 minutes, dancing, like, she mentioned earlier, just anything physical that gets that heartbeat up, it just goes a long way. But the biggest thing about my heart journey, I work with the American Heart Association. I'm a volunteer. It is my life goal to bring awareness, is to listen to your body, because your body does speak to you. We just don't listen. 2 or 3 months prior to my heart attack, I had shortness of breath. I mean, I couldn't walk from here to the front door. I was out of breath, and I worked out all the time. So I didn't listen. And my body was telling me then, hey, something's not right. And that was my artery shutting. So now I want everyone to listen to their body and just be aware that, just because it runs in your family, you can get hit with it, and you got to pay attention, because what you see on the outside is not what's happening on the inside. We have no clue, and we have to go get checked out.
Now, I think you've identified quite a few things that we see in the Latino population, right? Ignoring our symptoms,
Yes.
not admitting, not saying we have enough time. Everybody else is important but us. And
Correct.
again, women and cardiovascular disease is increasing, but it's something that we don't recognize. So,
Right.
Your message is right on in terms of we really need to be, your body. And
Yes.
so don't ignore it, the signs and symptoms that your body's trying to give you. So thank you. We're just so glad you're here with us, that you can share that message. And it's truly a miracle. So thank you. Thank you for that.
You're welcome. Glad to be here.
So going back to Carlos, given the relative ease of identifying high blood pressure and the availability of low-cost medications, how can we promote better diagnostics and treatment services to reduce high blood pressure in our Hispanic or Latino communities?
I think there are multiple ways. I mean, part of it is the way we organize our clinics. When people show up, it's routine, is a vital sign. And if it's present, it's important to pay attention and to, repeat it if necessary, and really talk. I mean, Erica brought up several points about health literacy, right? And humility. Understanding, I mean, asking people, okay, I'm telling you your blood pressure is high. What does that mean to you? I mean, I think that, oh, well, I have high tension. I have a lot of stress. No, do you have anyone in your family who has been affected by a stroke or a heart attack or is on dialysis? I mean, what is your context? But also understanding that for some patients, that may not be their highest priority, because they're talking about, what am I going to eat, and where can is my roof going to collapse? So understanding the context is very important in that context, and also encouraging community events where blood pressure is screened, but then having the appropriate follow-up to make sure that people actually get seen and evaluated and followed. And I think that it's important to also have a close follow-up. So in some cases, I mean, I ask my patients to measure their blood pressure at home and then give the numbers back. There are some people who get high blood pressure when they come to their office, but at home they're fine. And that's the exception rather than the rule, but I think it's important to acknowledge that. But I think it's also important to know, and we were talking about this earlier, that nowadays we have very effective medications who are, in a combination of medications or approaches, but it's not all medication. I think Erica brought up the importance, and so did Lucy, of food and salt and sodium. And there are ways to still eat really well and eat, but you don't have to give up flavor. I mean, this notion that, in order to be healthy, you need to eat flat food, that's not true. We can have very tasty food, but we need to be very mindful of, whether that's a sazon or the whatever we're using for cooking is helpful in connecting. And then physical activity. We also have to recognize as clinicians that some of our patients live in areas where it's not safe to walk. And is it because there are dogs around, or but helping them identify a place where they go. In San Antonio, it's really hot most of the time. So going to a mall, going to an area that is air conditioned and walking around there and finding ways to do it. I think those are all components that we need to encourage. But the main thing is to stay to when you are told that your blood pressure is high, and whether it's you see in the dentist or you're being in, just not ignore it and following up and making sure that we have a plan to know where you are once your medications are in. The other thing is, some of the common medications may have side effects that are not very effective. And like Lucy said, with respeto, I don't want to bring it up, but you know, what you're giving me is making me sick. My legs are swelling. I don't want to do that. Or I have a cough that doesn't stop. Or, you know, I have other side effects that are potentially a problem. So encouraging the conversation, encouraging that connection. In our case, we have a primary care clinic that has community health workers who then work with patients to help them understand and using language that is accessible. I mean, if I talk about cardiovascular disease and I talk about hypertension, but if I talk about heart attacks and derrames or strokes, that then is connected. And if I talk about elevated, high blood pressure instead of hypertension, I think that becomes a chronic condition rather than a situational condition.
Thank you. Pierre, would you like to add a comment?
Yes, Emily, I wanted to build on something that Dr. Allen just said that I think is really important, which is to also have a sense for what it means when you hear your numbers back from a clinician as to what hypertension is. And I think for some of us, it's also helpful to have a sort of a number to attach to what a normal, quote unquote, normal blood pressure or non-elevated blood pressure, as we're now calling it, or elevated blood pressure, or truly hypertension. And I think this is important because sometimes we get a number, but there's not a lot of interpretation around it. Or we go into a drugstore and we get a number, but we don't know what it means. So while there's some complexity, I think it's worth giving some specific numbers behind blood pressure. And so there are two numbers for blood pressure, an upper number and a lower number. One is the blood pressure roughly when the heart is contracting. The other is the blood pressure in the vessels when the heart is relaxing. The upper number, if it is under 120, we could consider that to be the green zone. That's pretty good. And if that upper number is between 120 and 140, we'll call that the yellow zone. And if there are other risk factors, and if someone is really at high risk for a heart attack or a kidney failure, maybe there's a need for treatment. And if it gets over 140, that truly is what we would call hypertension. And in the majority of patients, it's better to move towards some kind of a therapy in order to drive down blood pressure. So I did want to give some specific numbers to blood pressure to help guide some of the thinking.
No, perfect.
And the lower numbers,
Please, Dr. Allen.
I mean, you know, we talk about 80 in under 80 to be what we expect, but also between 80 and 90 and 95. So sometimes you can have the higher number in the yellow zone, but the lower number is also important. So I think it's important to look at the whole picture in that sense.
No, that's great. Thank you. Thank you both for clarifying that. And Lucy, you know, maintaining your blood pressure if you're on medication, medication adherence is important. Can you talk about perhaps some of the reasons people give you why they don't want to stay on their medication, and what do you tell them of, you know, the importance for staying consistent and taking their medication?
There's several reasons that may come into effect. Is some might feel fine, right? So others is that they may not be able to afford it. They don't have the medication. They take it when they feel well or they don't feel well. And they didn't know how to call in to get a refill, so they ran out. So there's multiple different barriers that occur. And I think as a clinician, a physician, it's really teasing out what it is, right? We shouldn't just label the patient non-compliant. There's always usually a reason. So teasing it out, is it health literacy? Is it cultural understanding, language? Is it other barriers that are impacting them? And then from there, trying to guide them to say, this is why it's so important. And sometimes I put a personal touch in it that, you know, I tell them, I'm like, my mother died from a stroke and my father died from a heart attack. And that is what also pushes me to be a primary care physician in the Latino community, is because I want to help improve health and educate. So it's really meeting the patient where they're at, understand, and feeling like you're partnering with them to help them and not putting just a label on them.
Thank you. Erica, you talked a little bit about, you know, having known your symptoms, and, you know, what would be your message to Hispanic women and men about, you know, what signs were there that you think you should have known about, and what's the one thing you wish you could have done differently?
The one, I'll answer the second part. The one thing I wish I would have done was listen to my symptoms months prior to having my heart attack. In women, we do get chest pain, we get back pain. Typically, your left arm goes numb. You feel nauseous, headache, you get that clammy feeling. Those are some symptoms. Everyone is completely different. But at the end of the day, it's if you don't feel good, if you have one doubt, is please go get checked out. You know, the worst thing they can tell you is you might be having a panic attack, because, you know, those symptoms mimic each other a lot, but at least you know at the end of the day. One thing I do want to bring up, especially in the Latin culture, we're very stubborn. We're very like, you know, we're fine, we're good. I don't have time for this. One thing when I was younger too, that I wish I would have known and paid attention to, was I had like the white coat syndrome. So anytime I go to the doctor and they take my blood pressure, it's always high. And it's because you're kind of like, you're freaked out or you're scared, you're stressed out at the moment. But no, you have high blood pressure for a reason. So look into it. And definitely, you know, get on a treatment plan, because you can prevent from having a heart attack or stroke or anything like that.
Thank you so much. Pierre, you know, uncontrolled hypertension is a significant source of cardiovascular mortality in our Hispanic Latino population. What is Genentech doing to kind of increase the number of studies in high blood pressure among our different Latino populations?
Really important question. And earlier, Carlos alluded to the fact that we have progressively an improving understanding of what drives high blood pressure in terms of the response of the cardiovascular system to sodium, and the types of interventions that can be put in place that can lower blood pressure over time. And so currently, as Genentech expands its areas of focus, we are moving into the space of cardiovascular and metabolic disease. And we are now in investigational modes with other partners to find new medications to drive down blood pressure over time and expand our portfolio of products that we can use to address uncontrolled hypertension.
And that different types of medications are important for different population groups. That's in terms of what we're learning, right, from our different clinical trials, and was mentioned earlier by some of our clinicians about looking at the variation. And, you know, within the Hispanic population, we see just our ancestry is so wide, from European to Native American to Central African, you know, and so the variation in the risks that our population has are also important to consider in the clinical trials and the treatment approaches. So, Carlos, yes.
Well, a related question in terms of the variability is the fact that also many of our populations experience different levels of oppression, of racism, of microaggression. And that's a chronic cause of hypertension, and as the body responds to that. So I think it's also the notion of acknowledging that the context in which we live, in the context in which many Latinos live, are also not generationally. It's something they carry through in terms of trauma that is important to acknowledge, and sometimes it's manifesting say a chronic disease, whether it's diabetes or cardiovascular disease or hypertension. So I think that's, you know, yes, we have different genetics, but we also have different contexts that may make things worse in that context.
Thank you. I have a couple more questions, but I encourage the audience to also put in questions if they'd like. Lucy, you wanted to add to this?
Yeah, building on what he had to say. So my mother, she was the best patient, you could say. She found out she had diabetes, high blood pressure, everything was under control. She got off a medication for diabetes. It was a stressful event, and it was due to finances because of the wealth gap that impacts the Latino community that triggered her and made her have a stroke, a severe stroke. So I'm just going to stress what Carlos said. It's what impacts our community, what oppressive things, stress, violence, because that does have cardiovascular implications. So us being physicians in the front line and together and providing education and getting research to learn more about this, but also in terms of policy and what we ask the national and the federal and state and local level, what policies they're placing on for our communities to improve their health are key. Because if we don't have good policies in place, it impacts the health of our patients.
Thank you. Thank you so much. We're learning so much about social determinants of health, right? And the impact that that has. And I'm leading a task force of Hispanics to look at it from a cancer perspective, but so much of it is really environmental, policy related, the social determinants of health. So how can we work as a community to make health equity, something that we can all achieve, I think is extremely important. We have some great questions that are coming in. One of them is how affordable, and I'll open it up to the panel, whoever would like to respond. How affordable are hypertension medications? Pierre, you want to take that one?
Yeah, so I'll jump in. There's a wide variety of blood pressure medications, and affordability is largely driven by the cost of the drugs, of course, but also the coverage, the healthcare and coverage and insurance of individual patients. And so there's really a wide mix of the types of drugs that are available and their cost, and also the combination of costs and many of the social factors like exercise and diet and stopping smoking and other efforts as well. So they come together collectively to try to address high blood pressure. But there is a wide range in the cost of antihypertensive drugs. And I would say that it's an important conversation with one's provider, which is making sure that the cost of the drug is not a driver, is not a barrier to access to care. And then, of course, the downstream potential impact of uncontrolled hypertension.
Thank you. Another question is on symptoms. Any of you'd like to address? What are some of the symptoms that our community should recognize? Carlos or Lucy?
So I think it's important, one, and Eric had mentioned this, if you feel good, it doesn't mean you don't have hypertension. So, just there, yeah, sometimes you can get headaches. Yes, sometimes you can feel like your chest is a little tight, and sometimes you can have excessive fatigue. But just because you don't have those symptoms, it doesn't mean you don't have it. And just because you don't have those symptoms, it doesn't mean it's well controlled. So I think that's why it's El Asesino Silencioso. It's coming back to the beginning there, because it's not going to scream at you. It doesn't scream, your blood pressure is high. In fact, sometimes the blood pressure is high and it's like, I'm calm, I'm sitting here, I'm doing nothing. And again, it's a body response, and it's a global chronic condition, and it's not just related to tension. And I want to emphasize that, because there have actually been studies when people label it hypertension, they said, well, I am feeling fine today, I don't need to take my medication. When people call it a high blood, they take the medications because they think that the blood is thick and you need to do it all the time. And those were cultural studies that were done many years ago. But I think that makes the point that it's not a tension issue, it's not a stress issue, it's a condition that is fake blood, is one way to think about it. It's just your body needs help addressing and reducing and preventing the complications that can come from that. And I think that's an important piece that needs to be emphasized, that you're not going to have symptoms. I mean, yes, if you have symptoms, you have headaches that are not going away, check it out. But hopefully what will happen, and again, I want to stress the point that for Latinos, 1 in 5 will get hypertension after not having it in 6 years. So it happens frequently, and we need to sort of stick to the numbers that Pierre was addressing before. Because if you're not paying attention to the numbers, you still may have it, and you say, "Well, I feel fine," and then getting into the habits, walk 30 minutes every day, or at least for 5 days a week. Be mindful about fruits and vegetables. You can still eat well, and be mindful about your salt intake.
Thank you.
Can I add to that too? Because Carlos is so right. There's so many times where I've taken my blood pressure medicine and I feel fine, but then it was high, and I'm going, okay, see, it's just crazy. You really never know. And we need to take our part in doing homework and taking care of ourselves. So, we have watches now that tell us blood pressure. I ordered a wireless blood pressure. So I wake up, it's next to my bed. I do it first thing in the morning. I do it before at night. Or if I feel off, I'll continue to do it, and it keeps track on my phone. But as humans, we need to take, responsibility to make sure that our numbers are good. And if not, how do we correct it? Right. And taking our medication. Yes, I'm the first one that I'm tired of taking medicine all the time. But in order for me to stay alive and healthy, I need to.
Exactly. No, that's a great point. Thank you so much. And Lucy, what are some of the other risk factors that contribute to high blood pressure?
So we talked about diet, environmental factors, genetics. We also other chronic conditions, right? Our patient population has a high risk in terms of diabetes, obesity, depression, right? Dementia. All the things are related in terms of can increase your cardiovascular risk. So it's really making sure you go to the doctor regularly, right? Get the annual checkup. And I'm going to encourage Latino men, please, you're healthy. And if you're healthy, you think you're fine, but you really need to go see a doctor at least annually to figure out, get your blood pressure checked, your A1C, and different other preventative screenings to see where you're at. And then that can guide how often you see the doctor or not. Because as Carlos mentioned, and Erica, you really usually feel fine until it can be a little bit too late.
Great. Thank you so much. And Pierre, we're getting some great questions from our audience. And one of them, she's actually a community health worker here in San Antonio and is working on some adult biometric screening. And her question is, to diagnose hypertension, how many measurements with elevated blood pressure readings does a doctor need to confirm a diagnosis of hypertension?
Yeah, that's a really important question, because it really does take multiple points of diagnosis and assessment of blood pressure to have and hold the diagnosis of hypertension. So it's a really important point that it isn't a single point in time, with some exceptions where there's just excessively high blood pressure needs to be managed as an emergency. But generally speaking, 2 or more episodes of hypertension that are detected by a provider drives the diagnosis of hypertension. So it's an important point that it's not a single reading that drives high blood pressure. And in fact, sometimes the cuffs can vary. So blood pressures can vary from day and time of day and after dietary changes. So it's important to have more than one assessment of blood pressure.
Thank you. And another related question, so Carlos or Lucy, blood pressure measurement in severely obese patients, is it acceptable to measure the blood pressure in the forearm of the obese person instead of the upper arm?
What would be more appropriate is to get cuffs that are appropriate size, the large, extra large cuffs. And I even recommend for the patients, some patients get the wrist cuffs. And I said, no, what is standard and what we do in terms of studies is the upper arm cuff. So that is the best way. And so if your clinic doesn't have it, or the patient doesn't have it, is asking either provider or the administrator to order large blood pressure cuffs. And then for the patient, the provider can refer them into the insurance in terms of getting an extra large cuff. Because the main thing is get the appropriate equipment so we can make the appropriate diagnosis. If it's white coat hypertension, right? So when you come to the visit to the doctor versus this is true hypertension and we must treat it to prevent complications.
Thank you.
In addition to the cuff, and I think I agree with that. In some cases, you might need to get a thigh cuff because it's so big. But it's also important to teach patients how to take the blood pressure. If they're standing up and their arm is straight up, that's not going to work. They need to be seated. The arm has to be relaxed. I mean, though there are steps that are important to take to do it. And as a patient, it's important when somebody's taking your blood pressure and you're standing and connecting and say, no, I need to be sitting and I need to be doing it properly. So there are videos and other ways to learn how to do it. But I think the point is the studies are done with a specific protocols. And I think it's important that we follow those as we try to do that.
Thank you, Carlos. Appreciate both of those responses. Very, very difficult. And as we find that a lot of these comorbidities that we see in the Latino population, bringing the clinician has to do quite a bit of work to sort these things out. Erica, what are some of the ways that you're sharing your story, and what kind of resources are available through the American Heart Association?
Yes. So I'm a huge volunteer for the American Heart Association. Anytime there's a seminar or I need to go, there's a heart walks that's, always once a year in Dallas. It's about to happen. Videos, I have just done it all. But for major resources, go to the American Heart Association website. There's just tons of resources, information, how to take your blood pressure, what are your numbers. A lot of people still need to know that a little bit more. Preventative ways, there's recipes on there. There's just an abundant amount of resources online that can help you research and help you guide you through that journey to avoid something major happening.
Thank you. Lucy, oftentimes a patient says, I want to see a doctor who understands me, who is my same race or ethnicity. But we know there's just a low number of Latino clinicians and African-American clinicians. So, how is your NHMA Leadership Fellowship helping you on this journey?
Well, I encourage many of my Latino colleagues to participate in the NHMA Fellowship just to learn more about policy, because there's a different spectrum of how as physicians, being the few Latino physicians, how we can use our voice. So we can use it in the clinical setting all the way into the political spectrum, depending on what you want to do and what your availability and passionate about. So I think it's very important to partner with professional organizations, and they're trying to tackle the healthcare work shortage in terms of Latinos and other historically marginalized groups. So thinking about that. And the other aspect, it helped me figure out in terms of what I'm passionate about, right? So I know I'm gonna try to take care of my patients and increase it and help as many individuals who are Latino, get into the medical field. But it's also teaching others how to take care of our patient population and working together in terms of how to figure out how to take care of our patients, because we're still not there yet, right? In terms of reaching the numbers, in terms of physicians and healthcare workers that represent our communities.
Thank you. And you're right. We've got to work more in the policy arena, right? Carlos, you mentioned a lot about social determinants of health. How are clinics handling that nowadays? And where we can provide not only the health care that our patient needs, but perhaps some of the other resources to have them pay attention more to their health care.
Well, I think that, one of the things that we need to realize is that trust is the secret sauce to effectiveness in clinical work. So if you trust your clinician, you trust your team, you're much more likely to work because you're feeling heard, you know the story, you know that someone there cares sufficiently to make it happen. It's varied. I think, primary care offices are, there's a full spectrum. There are people who are just there for profit, and there are people who are really committed to changing the landscape. We have an advanced primary care team in our institution that includes a team of 9 community health workers who are part of the primary care team. So they're not added, but they're really embedded in the team, and they work with patients in their homes. They get the stories, because I mean, so much of it is hearing the story. But if you only have 15 or 20 minutes, it's hard to get the story. But they bring that to the clinician, and then we work together to make it work. And in some cases is, just understanding the complex of who's in the home, what are the influence, who's the cook, who's the component. But beyond that is also understanding that they also give them connections to community resources to address some of the social determinants of health. So I think it's a complex component from a policy perspective. At the National Academy of Medicine, there is a primary care committee that is pushing hard, working with the Health and Human Services to really come up with a primary care strategy that is based on changing the way primary care gets paid. It's changing who's included in the team, what is supported in connection, and all those pieces are going to be very important as we go forward to really make the majority of high blood pressure gets treated in primary care first. So understanding that that's what it is and how do we make it happen is going to be very important. But what Pierre was mentioning earlier is also the fact that we want to find the most effective treatments, and we want to find, in some ways, some people do well with 2 medications or 1. But there are others who are difficult to treat hypertension that require 6 medications or more. I mean, what are some of the potential opportunities to address that issue? And normalizing that and saying, hey, this is better than having you half paralyzed or really not being able to do other things.
Thank you. Pierre, yes.
Carlos brings up a really important point I want to make sure I stress, which is that while generally hypertension often can be managed by a variety of dietary interventions and modifying risk factors, and that's really critical, there are some patients occasionally that have versions of hypertension that require more specialized care and evaluation. And so therefore, when a patient or a family member is having more and more drugs added on, that makes it more difficult to treat and adhere. That means take reliably the medications. And often it requires a referral to a cardiologist or an expert that can do a bit more of a detailed evaluation as to what these risk factors are and what the nature of the high blood pressure is. Lucy?
Lucy, yes.
And talking about teams, right? How do we tackle like social determinants of health? Carlos touched on, there's that medical team we have, and the community health workers are so essential. And then our partnerships with our community-based organizations and faith-based organizations, because these are trusted centers in our communities, and partnering with them to provide education, or they have resources that we can refer patients to, or that they can go exercise safely. I think it's really a key to build that trust in the community and find out those and develop them so we're able to refer our patients.
Thank you. I have another question in the chat. This one's a little complicated. It says that when they had they checked their blood pressure, it was high, 166 over 101. But when they went to the doctor's office, it was normal. And then they were taking it at different times of the day. And the question is, why does it appear that your blood pressure goes up at night when your body's supposed to be at rest? Anybody want to take that one?
Yeah, I'll just jump in very quickly. Generally speaking, blood pressure does indeed go down when people are sleeping. But there is an important point here, which is that the point or the time of day does matter for blood pressure measurements. And so it's important to have consistency around the time of day when the blood pressure is measured in order to make a definitive evaluation of high blood pressure. This would be paradoxical to have blood pressure that was high in the night and then lower during the day. And when you see these kinds of patterns that don't fit the norm, that's when, as I think Lucy was referencing, sort of reaching out for resources for referral to more advanced care may be appropriate.
Great, thank you.
So a related point is, not all hypertension is primary hypertension. Some of it is related to a particular lesion, or some of it is maybe a tumor or some other sources of high elevated blood pressure. So I think being mindful of that and having a team that addresses that is very important.
Thank you. We're getting near the end of our webinar, and I'd like to give each of you a few, a couple of minutes to kind of, what would you like to tell the audience in kind of in wrap up? And I will start with Lucy.
That it is important. The medications are important, right? The exercise, but as Erica mentioned, to listen to your body and to prioritize your well-being, because like in an airplane, if you don't put on the mask yourself first, right, you can't take care of everybody else. So I very stress in what happened to my parents helped me reprioritize in life, and my messaging is taking care of yourself, mind, body, soul, spirit, and then doing the other aspects so that you can improve your health.
Thank you. Pierre.
Thanks so much. I guess I would end by saying that we've heard some stories about family members who have lost their lives, and often these deaths and this loss is preventable. And while respect is critically important and trust is important, we have to acknowledge that this condition of not managing these major risk factors for cardiovascular disease ultimately can result in early death and early morbidity. That means, major medical crises. And so I really encourage the audience to, as we began earlier, Amelia, is to know your numbers and know one's blood pressure and be able to have a conversation with both their providers and also family about making sure that the numbers are within the normal range so that patients can have a long and fruitful life.
Here, sometimes I hear people say, I have an enlarged heart, and so that's a good thing, that I have a big heart, but is there any association between that and high blood pressure?
Yeah, it's a fairly complicated topic. Happy to very briefly say that the blood pressure, of course, impacts the way that the heart functions, and over time the heart wall can thicken, and then under chronic conditions the heart wall can weaken and ultimately lead to heart failure and sort of an incapacity of the heart to appropriately pump. And that is an outcome that we, of course, want to avoid. And one of the main reasons for treating hypertension successfully is to prevent this downstream failure of the function of the heart.
Great. Thank you. Erica.
I think Lucy and Pierre nailed it on the head. Life is so precious. Don't take it for granted. Please listen to your body that is speaking to you, and react, make a plan, and, do things that are going to be preventative.
Thank you. Carlos.
I would say El Asesino Silencioso es de verdad. So is a real thing. And hypertension is confusing. You have high blood pressure. And if you have high blood pressure, treat it seriously because you want to prevent having all the complications. It's a lot easier to prevent. I mean, I sometimes tell my patients who smoke and they're not ready to stop. So it's okay. Most people do when they have a stroke or a heart attack or they got an amputated leg. So we'll wait until then. I'm sort of half joking, but the point is high blood pressure is a real thing. And you have the opportunity to treat it and it's really a window into the other cardiovascular risks. We didn't talk about cholesterol, we didn't talk about smoking, physical inactivity, and diet. All those pieces are also important in finding ways to connect. But if there's one liner, is hypertension is not tension. Hypertension is high blood pressure.
And what have you all found to be the most kind of impactful message that you can give your patients to really think about prioritizing their health? And I'll go back down the line real quick. Carlos.
I would say, do you know anybody who has a stroke? Do you have anybody who had a heart attack? Do you want to have one of those? No. Okay, let's talk about how you prevent it. I think that's, make it personalized and real to their community, to what they are, they have experience in their families and their friends.
Right. Thank you. Erica, what captures your audience when you're talking to them?
Yeah, when I say that I had a heart attack, they get scared. They're like, "You?" And I go, "Yes, exactly." Because if you don't know what's happening on the inside, you can't prevent anything, right? So take those measures. But yeah, I think just me saying I had a heart attack and the way I physically look on the outside just shocks people. So it kind of brings them a little bit more aware and gets them to do more.
Thank you. Pierre.
Yeah, I mean, simply put, I would say, we want to be there for our loved ones, and we want to make sure that we're there for our grandchildren and present for our families, and managing high blood pressure is really part of managing the health and wellness of an entire family. So I think of it as not being located in just one individual, but think about all of those around you. And by taking care of oneself, we also are there and more present for those that we care and love.
Lucy?
And I think one of the aspects that I use is the patient-tailored approach, really listening, that they know that I'm a partner in terms of trying to help them with their health, but they are the drivers. And so I need to know what's going on with them to help them to make success in terms of these outcomes.
Thank you. Well, gosh, y'all have just been an amazing panel. Thank you. Thank you so much for making time and sharing this very valuable information with our audience, and, trying to help our audience really have, a healthy heart. So we really thank you for that. We'll be adding the videotape to our YouTube listing. So go to saludamerica.org to be able to download and share with other participants if you'd like. And also, I'd like to share with you a tool that many our local health agencies have been using to identify local health issues that they can address in their communities. It's called the Health Equity Report Card. And it really shows you what are some of the main issues in your community. You just put in your zip code, and it's amazing. And you can take this to your city council and others to start saying, we want to create a change. We want to create a healthier and more equitable community. So again, we thank you all for your valuable support today. Thank you to the audience for your great questions, and everybody have a wonderful day, and we appreciate all your help. Thank you.